Today I will be talking to y'all about atrial fibrillation, which throughout this PowerPoint I will refer to as AFib. AFib is the most common arrhythmia worldwide, affecting 33.5 million individuals. There are multiple risk factors including hypertension, heart failure, valvular disease, and obesity. Over time, these risk factors cause physiological aging on the heart, as well as cardiac remodeling, and both of these can cause structural remodeling of the heart, leading to triggers that initiate and maintain the arrhythmia. There are thought to be multiple reasons people develop AFib, which these reasons are still being researched. A significant amount of patients are asymptomatic. When patients do have symptoms, they can include palpitations, chest pain, lightheadedness, dyspnea. On physical exam, you might find an irregular or rapid pulse. A complete cardiovascular exam should be done on patients with newly diagnosed AFib, as well as a full and thorough history. Upon exam, you might find other symptoms of the possible cause of the patient's AFib, such as a patient who has heart failure might have peripheral edema. That might lead you to the cause of the patient's AFib. Asymptomatic AFib has been linked to increased risk of stroke, and this is thought to be due to the fact that the patient doesn't seek the proper treatment that they need. AFib is made with an electrocardiogram. The problem with this are patients who have paroxysmal AFib, which is the most common type. These episodes come and go spontaneously without medical treatment, and you might have a patient who is not having an episode of AFib during the recording, so will not show up on the recording. There are 24-hour Holter monitors and loop recorders that are available for patients such as this. An electrocardiogram will typically show erratic, disorganized atrial activity between discrete QRS complexes, and they are show an irregular pattern. This atrial activity may be difficult to detect or could be very obvious. The top rhythm on this slide shows coarse AFib with moderate ventricular response. The two characteristic findings of AFib are present: the very rapid atrial fibrillatory waves and the irregular ventricular response. So the R&R interval between beats is unpredictable. In the bottom strip, it represents minimal atrial activity, and the only finding suggestive of AFib in this strip is the irregular ventricular response. An echocardiogram should be done on patients being diagnosed with AFib. This is to look at the structure and the function of the heart, as well as the presence of any thrombi. This should especially be done for patients who might need cardioversion or an invasive procedure due to the possibility of embolization. Additional testing such as TSH should be done to rule out hyperthyroidism as a potential cause of AFib, and to rule out other risk factors such as a screening for diabetes and a BNP to assess heart failure. Now on to treatment. Treatment consists of rate control and rhythm control. Rate control is usually achieved with beta blockers or calcium channel blockers. Rhythm control may be used in patients who have symptoms despite rate control, and rhythm control can be achieved by cardioversion, antiarrhythmic medications, or ablation. Ablation is used a lot for patients with drug refractory symptomatic AFib. Stroke prevention is an important primary goal in management of AFib. To look at the stroke risk of patients, we use the CHAD-DS2 VAS score. This score takes into account risk factors and gives them a score of 1 or 2. Congestive heart failure, hypertension, diabetes, vascular disease, age 65 or in between 75, and the female sex all get 1 point. Age greater than or equal to 75 and a history of stroke or TIA gets 2 points. A score of 0 recommends no antithrombotic therapy. A score of 1, antithrombotic therapy includes oral anticoagulation or antiplatelet therapy, which are either one of those are recommended. And for a score of 2 or greater, oral anticoagulation is recommended. Warfarin is the standard therapy of oral anticoagulation. There are also others, Pradaxa and Xarelto. Aspirin is the antiplatelet therapy used. Prevention of complications is aimed at patients receiving treatment for their underlying cardiovascular risk factors, such as their hypertension or obesity or diabetes. Treating these may prevent the progression of cardiac remodeling, which may prevent the onset or reoccurrence of AFib. Physical activity and weight loss have recently been shown to significantly reduce AFib burden. It is important that we educate patients on the signs and symptoms so that patients know when to seek treatment. These are my references that I used. I hope you enjoyed this presentation, and good luck on the boards.